Hi, my name's Peter Goadsby, and I'd like to thank the organisers, the Organisation for Understanding Cluster Headache UK, for asking me to speak. I want to cover some of the developments in our understanding of cluster headache that have emerged over the last few years in its treatment and the interaction between the two that allows us to understand the disorder better. It's too bad we can't have this in person. Things have gotten even more difficult in recent weeks. We haven't had the opportunity to meet for some time. I do look forward to be able to do this in person, I hope next year. For the moment, make the best of what we have. So cluster headache is one of the trigeminal autonomic cephalalgias. That just means pain, trigeminal pain, which is head pain, and autonomic cephalalgia is the association of the head pain with symptoms like eye watering or redness or nasal congestion or ear pain. These are the so-called cranial autonomic symptoms. And there are a collection of headaches that do this. The most common is cluster headache. There are cousins, you might say, paroxysmal hemicrania and SUNCT and hemicrania continua, and I won't cover those. We could happily cover them in the question time if people wanted. This is the definition, the official, if you want, International Classification of Headache Disorders definition for cluster headache, and that hasn't changed much over many years. Cluster headache hasn't changed for the longest time. It's the attacks, typically one-sided, very severe, lasting for many minutes, up to hours, but not for many, many hours and days, unlike migraine. And these cranial autonomic symptoms that I spoke about, variable frequency. And we divide the disorder into episodic cluster, where the ICHD considers that pain-free remission should be at least 3 months, and chronic cluster headache, where those remissions don't occur. Now, there are lines in the sand, and the broad concept, which is a really important concept, is that the majority of people with cluster headache will have the disorder stop and start. And whether the bout, so to speak, or cluster period lasts for 8 weeks or 6 weeks or 12 weeks is important, but not the core interesting thing, which is that it stops between bouts, unlike chronic cluster, which really never stops. It's fundamental, I think, to understanding the disorder, to understand what is it that makes the bout stop. So I think if we understood stopping, we could really make it, I guess if I was to say, make a cure difference if we could. So why do some people have cluster headache and why others do not? These are 2 papers that were published back to back in the Annals of Neurology just this year, which used a technique called genome-wide association study to try and determine if there is an identifiable genetic basis for cluster headache. In one study, the UK and Swedish study, 852 and 591 people with cluster were compared to a larger cohort without cluster, while in the Netherlands and Norwegian study, predominantly genome-wide association, again, 840 and 144 people were compared. The idea of genome-wide association scores is to try, studies, is to try and see if there are things about having cluster in the genetic sense that others without cluster don't have. At the bottom, the 2 figures are what are called Manhattan plots, because they look like a Manhattan skyline, which is in the eye of the beholder, I suspect. And the peaks, the ones that are going above the dotted line, and there are 4 of them on the left side in the UK-Swedish study, and there are 4 of them on the right side in the Netherlands, the Dutch and Norwegian study. Interestingly, they're all the same genes, chromosome 1, chromosome 2, and chromosome 6, which is interesting to start with. And remarkably, at least one of these, MERTK, is identified in both. Now, these are unlikely to be genes as such. Indeed, one of the chromosome 2 identified in the UK-Swedish studies, intergenic, as in coding between the gene. But what they do is point to areas of the genome, areas of what is inherited that need exploration to try and understand if that is where some of, at least, the responsibility, you might say, of getting cluster headache lay. So this is all the work in progress. As with most research, you would say that more is needed, larger studies are needed. But these are very good starts. There's some interesting data came out last year looking at diagnostic delay. This is depressing for those of you who've had delay. On the table on the right, at least it shows that things have improved. It's very similar to the data that Nish Barr and I collected together some years ago. So it's getting better, but it's certainly not wonderful. On the left is an analysis of why some patients do not get diagnosed. So you see on some of the things that do that are being female, for example, is not entirely helpful. Having an alternating side to attack or less than severe pain or absence of restlessness can also be somewhat, you might say, unhelpful. But a long duration of attack and migraine-like features are particularly troublesome in terms of making people think that it's not cluster headache. Education is, of course, how we move this problem forward. Now, in the context of that, in the context of duration, in the context of understanding, I've always been drawn to the work that has been done on circadian and circannual periodicity. And I put this up just to highlight that. There's a number of things that are being done, because this exquisite timing of the disorder, if you see on circadian, which is the 24-hour clock, that most patients will report their attacks in the early hours of the morning. And then the circannual variation, which is the really big picture thing. The peaks seem to be in the dark months, so to speak. And this is Northern European data. This is from the Danes, with relative troughs in the lighter months in summer. I think this circadian variation is a real window of insight into understanding how attacks change and how we might think about targeting treatments to stop them. I want to mention some of the treatments that have been studied and the outcomes that we've had in recent times. Some good and some not so good, and this is an example of one that's not good. So on this list is the management of acute attacks, oxygen, sumatriptan, zolmitriptan, and the vagal nerve stimulator. They're, you might say, established with clinical trial results. Investigational, I just wanted to point out one that was done and completed and unfortunately failed. So some years ago, we did a study comparing octreotide, which is a somatostatin receptor agonist, so it turns the somatostatin receptor on, and we saw pain relief versus placebo. There are 5 somatostatin receptors. So pasiritide was studied, SOM230, which is particularly potent at the somatostatin receptor 5. It's got a 12-hour half-life, was compared to placebo, given subcutaneously, sequential design, and what happened, pain relief again at 30 minutes, it didn't work. It's disappointing, although on the other side of it, a clearly negative study with something like this that's quite potent at the somatostatin 5 receptor does tend to take that out of the game, so to speak. So it's still knowledge. The CGRP receptor antagonists that have been developed, the small molecule GPANs, have not yet been tested, and I really hope that we could get to do that at some point, because I think they hold great promise. When I look at preventive management, I just want to focus on prednisolone, because there's a new study that's come out. People have been using corticosteroids, prednisolone, over many years, and we now have a randomized placebo-controlled trial it was an add-on trial to verapamil, 100 milligrams per day for the first 5 days, and then a taper, 20 milligrams every 3 days. The primary endpoint was the number of attacks in week 1. And as you see, there's less attacks in week 1 on prednisolone, that's the 53 patients compared to 56 on placebo, and that p equals 0.02 says it's significant. This is something people have been doing for a long time, and it provides a solid evidence base to continue to do it. And that's important for lining up on this page all the things that we can do as short-term prevention for cluster headache. Now, some of you will be familiar with the use of the vagal nerve, the non-invasive transcutaneous vagal nerve stimulator in cluster headache, and the two studies that have been done, one in the US and one in Europe. And I draw attention to the results, and it's not universal because obviously there's individual variation, but overall, ECH at the bottom is episodic cluster headache and CCH is chronic cluster headache. This is a pooled analysis that took both of the studies. And so using endpoint 1, which was in the first of the studies, Act 1, so to speak, which was pain relief at 15 minutes on the first attack. Episodic cluster headache, 39% of patients, 12% on the sham, compared to chronic cluster headache, where there was no difference, perhaps doing a little bit less well on the active stimulator. And then Act 2, pain relief at 15 minutes in all attacks. Again, episodic cluster headache, 24% for the device and 7% for the sham. And again, the same contrast with, in fact, less patients doing well with chronic cluster headache. And the overall message from this is pretty clear, that this device is useful, potentially useful, for patients with episodic cluster headache, but not so much for chronic cluster headache, which is, at least in terms of the attacks. It's a theme I want to return to because it's giving us some insights into the differences. So mechanistic difference, calcitonin gene-related peptide, CGRP, big news in migraines, released in cluster. That's why doing the episodic study, the acute treatment study would be useful with a GPAN. And what the Danish group did here was to infuse CGRP to try and trigger an attack. And they did it in episodic cluster patients who were in a bout, and 8 out of 9 had an attack after the infusion, and only 1 out of 9 on placebo. Whereas with episodic patients, when they're out of a bout, none had an attack with either CGRP or placebo. In keeping with it's turned off out of a bout. Whereas with the chronic patients, 7 out of 14 with placebo, 7 out of 14 with CGRP, none out of 14 with placebo had an attack. Now, interestingly, the cluster headache responders in this group, the chronic cluster headache responders, had 33 attacks in the previous 30 days, whereas the non-responders only 7.5. So they were more turned on, so to speak. And it's consistent with the concept that the chronic cluster headache patient is turned on to some extent all the time, which is a variable, which has some variability in contrast to the episodic cluster headache patient. This is work that Diana Way's been doing, and grateful to everyone in Ouch who's been involved in this, to try and, again, dissect out the difference between episodic and chronic cluster headache. This underlying idea that understanding that is important to grasp one of the real real goal, which is to turn these attacks off permanently. So single blind is nitroglycerin triggering. 16 of 19 episodic patients triggered and 11 of 14 chronic patients. There were no cranial autonomics. There were cranial autonomics without headache in 5, interestingly enough. Now on the left is what's called a Kaplan-Meier plot. It's a survival curve, and it's a survival curve of not having headache. So at time 0, everyone's given the infusion, and you see as the steps go down, more people get their headache, so they don't survive with no headache, so to speak. And notice the solid line is episodic cluster headache, and it comes on faster compared to chronic cluster headache, which is coming on slower, and going down ultimately to only 20% per people at 140 minutes. Now on the right is a way of looking at the attacks in detail. It's called a violin plot. The little dashed line in the middle is what's called median, and on either edge are what are called the interquartile, so 25 to 75% range. And the breadth of the plot shows you how many people were sitting at that particular time point. So if you contrast chronic cluster headache and episodic cluster headache, you see that pain develops much quicker in episodic cluster headache, both the mild and the maximum pain. And whereas the cranial autonomic symptoms don't have a huge difference. The median is delayed, but the bulk of it is occurring earlier on. Non-headache symptoms are much less common in chronic cluster headache than episodic cluster headache. We hope to use this kind of information to be able to think about how to understand the attack development and particularly the head pain development versus the cranial autonomic symptoms. This is the monoclonal antibody story in cluster headache, which is exciting, a bit disappointing from what the European regulators have done, it has to be said. So episodic and chronic cluster headache were studied separately with galcanezumab. The episodic studies, double-blind, placebo-controlled, 10 to 15-day baseline, then 300 milligrams subcutaneously, 49 patients in galcanezumab, placebo was 57. So the primary endpoint, the main test, is the weekly attack rate between the first 3 weeks, minus 8.7 attacks for galcanezumab, minus 5 for placebo, which was significant. And then the secondary is the 50%, how many people lose half their attacks, 70% galcanezumab, 50% on placebo. Interestingly enough, the patients were asked when they had the patients were asked if they had a global impression about the improvement. And those who said they had much better, were feeling much better, had at least a 43% reduction. And I say that because it makes the 50% number seem pretty sensible. So nice study. And at the bottom on the left is the diagram from that, and you see the black of the placebo and the red, the galcanezumab, being separated until week 4, which is what you'd expect for episodic cluster headache because the bout stops. So whatever you did, the bout stops. You expect them to come together. I regard that as a reality test, but the European regulators didn't quite see it that way. Life. And the difference between the two, if the clear blue water is the effect. Now, if you look at the chronic cluster headache study, similar sort of baseline, 300 milligrams versus placebo, the mean change in attack frequency over 12 weeks, the whole 12 weeks, and it wasn't significant. But if you look at the first 2 weeks, the number there, the p-value is 0.006, which is significant. Clearly, there is a difference between the placebo reduction and the galcanezumab in the first instance. Perhaps this is an insight into what's going on, that these treatments are good for arresting the shortest part of a bout and probably useful in chronic cluster headache, but not in all patients. And that'll probably depend on this attack frequency, which is something that the Danes, of course, highlighted when they did the triggering study. Now, the other comparison is with the, sorry, I have to build this one, is with the fremonizumab, which also looked at episodic cluster headache, and their conclusion was that it was not significant, but they used again an endpoint there at 4 weeks instead of looking at the first 3 weeks. And you can see again that there's this blue water, you might say, between the two, the placebo and the low-dose fremonizumab and the high-dose fremonizumab, if you look at earlier time points. Bearing in mind the prednisolone study that I showed you used 1 week as the endpoint, I do think that probably the right endpoint is within these first 3 weeks. And lastly, I want to show you latest occipital nerve stimulation study in chronic cluster headache that's been published, a so-called ICON study. These are patients with chronic cluster headache with at least 4 attacks a week who'd failed 3 previous preventives, who had 24 weeks of ONS with the endpoint being tested in the 21st to the 24th week. Now, 66% of them had a 30% stimulus and 65 had 100% stimulus. The way that was done was the stimulator was turned on in individuals to just detection of paresthesia or near discomfort, and then using that as a range, 30% was 30% above just detection, and 100% was just under a discomfort. And that's the way the two were compared. Now you can see from that, what you might describe as a spaghetti plot on the right, which shows everything, that the mean attack frequency and the weekly attack frequency, they decrease, but they decrease for both groups, the 30% and the 100% stimulus group. And you see that reflected in the median attack difference, which is -2, with a so-called confidence interval is -5 to 3, so it's straddling 0. The conclusion the authors had was that the ONS is effective, and clearly you don't have to be running it at 100% to get the same effect. The big problem with neuromodulation studies is how you control them, what the control for sham is, so to speak. And this is a really good way to move forward, but the limitation is always going to be with any nerve stimulation to try and work out how you can dissect away the placebo effect and the time effect from an effect of the stimulus. We're getting better at understanding cluster. The genetic work is important in this, and we've done some imaging work we will certainly be presenting to you next year. We're exploring the acute attacks, see the treatments that are becoming on offer. The preventive management is difficult still, and I think that's because we don't have enough targets moving forward, and that's something that we're working on in the laboratory. It's a devastating disorder. You know that better than I do. Our ability to study it and understanding it is getting better. And I'm sure if we could just dissect out what's happening between episodic and chronic cluster headache, we would have a real way forward. Thank you.